So welcome to the Academy of Consultation Liaison Psychiatry's first virtual forum, where today we'll be discussing consultation liaison psychiatry in the era of the COVID pandemic. I'm Marilyn Powell, and I'm one of your moderators today, along with Paul Desant, Chair of the Education Committee of ACLP. These are our objectives today, and I won't read them to you, but we have a wonderful program ahead for you.
So thank you for joining us. Our web forum will be divided in two parts. We'll have questions and answers after the first hour and then questions and answers after the second hour. The speakers in the first part will be Damir Huramovich, Yesne Alici, and Lisa Rosenthal. And in the second half, we'll have Nasu Malas, Priya Gopalan, Vera Foyer, and George Everly. It's a terrific program. If you have questions, you can type them into the chat box, and the moderators will read as many questions as we can. Thank you so much for joining us, and let me turn now to the president of our organization, Michael Sharp.
Thank you very much, Paul. So my name is Michael Sharp. I'm joining you from Oxford in England. And as Paul says, I have the privilege to be the president of the Academy of Consultation Liaison Psychiatry. The COVID-19 pandemic that we have all been through and are still going through has caused huge challenges, and it's also giving us a lot of opportunities for learning. And I think at this stage, as we're past the initial shock and drama of this hitting us, and we're now going into perhaps a more reflective phase, it is a fantastic time to have such a webinar as has been led by Marilyn Powell and Paul Desant on behalf of the Academy. When we reflect over the last few months, and it is only a few months, I don't know about you, but it's made me very proud to be a physician. It's also made me very proud to be a CL psychiatrist. CL psychiatry has contributed so much to the response that has been mounted to this challenge internationally. CL psychiatrists have not only fulfilled our duty of seeing patients and adapted by doing this often remotely, but they've stepped up and helped our other physician colleagues who are often having a much harder time of the challenge that we are. I think it's been a great period for CL psychiatrists to contribute to the care of our patients. So the Academy has done a number of things to support our CL psychiatrists. We have a very heavily used listserv, and I'd encourage you to use that if you haven't already, whilst also bearing in mind, because it's heavily used, please keep your posts relatively short. We have this new forum that we're having now that Marilyn Powell and Paul Desant have organized, and this is a tremendous additional thing we're doing. And in the annual meeting in November, we're going to have special features on learning from COVID. The annual meeting is still planned to be occurring in Phoenix, and we're monitoring the situation and will adapt how we deliver it should the need arise. So I'd like to welcome you on behalf of the Academy to this listserv. I'm sure it's going to be informative and helpful. And my last word is, if you enjoy this and you're not a member of the Academy, please do join. Thank you.
Thanks, Michael. So we're delighted to get our first speaker who will open the web forum with a keynote address. Dr. Damir Huramovich is the only member of the Academy who wrote a book about the psychology of pandemics, and then through a bizarre accident of fate, turned out to be working at the hospital that was at the very epicenter of a pandemic. Damir?
Paul, good afternoon. Good afternoon to all of you, and thank you for this kind introduction. It's a tremendous honor to be given this opportunity to address you guys. In echoing the words of Dr. Sharp, these indeed have been challenging times for the entire human civilization and global society, and healthcare workers and CNL psychiatrists. And I'm really proud to witness that our colleagues, our brothers and sisters in CNL psychiatry have risen to the challenge and been able to provide and do their part in battling this outbreak. I wanted to give you a little bit of a context and the landscape of what we're dealing with so that you have a better understanding of how we're going to be proceeding and what are the issues that we have to grapple with in the coming months, weeks, and possibly years. And of course, to be ready for a different outbreak of a different kind should that arise sometimes in the future. Catastrophic pandemics have actually been occurring at regular intervals throughout human history. So the century that we had free of these outbreaks actually is rather an anomaly, not a rule. And all those outbreaks have affected the course of human history tremendously, including the development of medicine and even modern psychiatry itself, particularly the last one about 100 years ago. On its part, psychiatry, however, has given little consideration to such events and such phenomena until now, five months ago. Our mental health resources so far, including research, have largely been focused on infectious diseases that are what we call slow spreading, and they impose significant public health burden on the given society. For example, in the US, what we've been dealing with in the last decades have been the outbreaks or spreading of HIV or hepatitis C. The situation is different when a rapid outbreak occurs. Then mental health response is by default undertaken as a mental health response to a disaster, but that can only take us that far. So we really have to reconfigure other ways of addressing this issue. And I would kind of make an argument here that pandemic and epidemic outbreaks have some unique features, some crucial idiosyncrasies that make their mental health aspects unique. And I would propose that CNL psychiatry is the best area to handle mental health issues and to fashion a mental health response in such outbreaks. Here are some of these unique features. First of all, there is a time lag. Pandemic outbreaks have somewhat predictable epidemiological models that allow reasonable time for planning and preparation. We here had the lead time when it was happening and developing in China, and then Italy and Spain, and then finally it's here, and now we're witnessing that there is a new, basically, epicenter that's kind of spreading throughout the Latin America, namely in Brazil. Another unique feature is that it imposes a significant burden on caregivers, healthcare workers. We are at both increased risk for infection and at risk for emotional trauma and traumatic distress. There's a burden on facilities and healthcare system. Facilities may transform from points of care to nodes of transmission or be completely overwhelmed by the disease. There are unique issues associated with quarantine and isolation. And then, of course, you have psychiatric sequelae of having the illness and having survived the illness, its complications or complications associated with treatment. On top of that, you have something that happens outside of the healthcare centers, and that's the public perception, public fears, expectations, and misconceptions that result in a process that epidemiologically mirrors the epidemiology of the infectious disease itself. So we're really talking about the two pandemics. One is the actual disease, and the other one is this emotional or psychological disease that tends to spread pretty much following the same models. Just a brief example, but because this is fairly unknown and fairly new, what we can rely upon are experiences from our previous encounters with, for example, coronavirus. And the last one that we had was from previous decades. It was a MERS CoV, and it started about 8 years ago. So far, we've had 2,500 cases worldwide. So it was a pretty limited, I think 3 outbreaks so far, but geographically fairly apart. The cluster sources were usually hospitals, so it's reasonable to assume that many a transmission of COVID-19 happened also within the healthcare facilities. Still, there is no vaccine. They've been working on it for about 5 or 6 years. It has moved to phase 1B on April 20th this year. Case fatality ratio is pretty high, over 1/3 of the patients that contract MERS will succumb to it. And as you can see, respiratory infection leads to acute respiratory distress and acute kidney injury. So all of these things were somewhat associated with COVID as well, and that's probably the only limited experience other than SARS that we have had coming into this outbreak. However, in order to be able to deal with the outbreak of this magnitude and proportion, after the Ebola outbreak in 2014 and 2015, WHO has developed a panel that tracks and speculates on what the source of the next pandemic can be, and they render a blueprint for global action in case of a major outbreak, and they call that blueprint Disease X. So what they do, they basically put in place whatever they know, whatever they can speculate on, and then they wait for an outbreak to fill in the blanks and actually implement the plan that they have developed. It has a global coalition of experts in the field to estimate the scope and the magnitude of problems. Unfortunately, as of 2019, WHO panel did not include mental health specialists. And on the right side, you can see some of the candidates for Disease X, and definitely coronavirus is there. Let's just give a very short overview of SARS-CoV-2 and COVID-19 pandemic. It started 5 months ago in Wuhan in December of 2019. Within 2 months, it's been designated by WHO as a pandemic, as it exceeded 100,000 cases globally. By now, it has affected nearly all countries in the world, and it has exceeded 6 million confirmed cases. We had to turn in our slides a few days ago, so they're already obsolete, and that basically tells you about how very difficult it is to make any estimates and approximations, because the situation is so fluid and changes rapidly, and it has caused over 350,000 deaths directly. Indirectly, we're not sure. In the US, started in January in Washington state, and by now we have exceeded 1.75 million of confirmed cases and over 100,000 dead. In New York State alone, which still remains the epicenter, unfortunately or fortunately not for long, we are approaching 400,000 cases and 30,000 dead, most of them in Metro New York. We still don't know the true extent of this illness, therefore we cannot know the true case fatality ratio, which was estimated to be between 2 and 3%, but now has been down revised to 0.3%. It is definitely more widespread than originally thought. 20% of general population in New York City, and in some communities within New York City, it exceeds 40, it's up to 43%. About 12.2% of healthcare workers in New York downstate area have contracted and survived COVID. So paradoxically, working in healthcare actually seems to be somewhat protected because people take necessary precautions. Over 80% of confirmed cases do not require any hospital treatment. Less than 20% will require oxygen, and less than 5% will require ICU. But then again, as we are understanding the true epidemiology, of course, these figures may not make any sense or have any meaning in the coming weeks. Let's look at some of the features of a rapidly spreading pandemic. Pandemic outbreaks have predictable epidemiological models. unlike many other disasters which can just happen unannounced. So you have stochastic and deterministic compartmental mathematical models that can tell you exactly what and how it's going to happen, or at least can give you an estimate. And as we have learned, again, in case of this outbreak, they can be terribly wrong. They will, however, tell you approximately how much reasonable time you have to plan and to prepare for the pandemic, and how to identify more vulnerable or more resilient populations. Also, you can have a feature where perceived risk and uncertainty generate a significant concern or panic in a population, which clearly has unfolded in here. And health workers in pandemic outbreaks are at an increased risk for infection and work under considerable stress. It gets reiterated over and over again. Happened during SARS, happened during H1N1, during Ebola outbreak, and now during COVID. And that leads to a possibility that healthcare facilities can become overwhelmed and then become the nodes of transmission. There is also a risk for bioterrorism, which we are not going to go into during this presentation. What we are dealing with really is a black box full of unknown variables. There's very little research that tells us how to prepare general population, and one from 2004 called Redefining Readiness suggests that the general population may not react to a public health crisis in the manner anticipated by emergency management professionals. Exactly. Unanticipated behavior can complicate the management of a disaster situation and lead to higher rates of long-term mental health problems. Just to give you an example, Americans, that was done again a while ago, are twice more worried about smallpox vaccine than about contracting smallpox themselves in an imagined scenario. And I think we're having the same scenario playing out now as we are discussing the possibility of a COVID-19 vaccine. Again, we need to bear in mind that contagion exists also as a psychological concept, that there is a thing that we call emotional epidemiology, and that we are basically having a shadow pandemic, a shadow emotional outbreak that follows and mirrors the actual outbreak. You have a lot of panic. And that's related to the perception that there is a limited opportunity for escape and a high risk of being injured or killed, or that the help will be limited and available only to certain populations. Let's look at a little bit of effects that pandemics can have on our existing mental patients. Of course, that as there is interruption in care, people with existing mental health issues may experience setbacks, relapses, and impairment of function. Those who predominantly present with anxiety disorders may experience worsening of their symptoms. Some of them actually may be prompted to do some proactive and protective behaviors. With increased strain on society, patients encounter obstacles to care, and you have travel bans, or you have a complete shutdown like we have been witnessing in the recent months. And when you have a breakdown in social services or during severe precautions, then mental health system is at risk of falling apart. And there definitely will be insufficient specialized services for the increase in needs, such as counseling for survivors or bereavement counseling for the relatives. There is also known effects of a pandemic on healthcare personnel, because, as we said, it puts a lot of strain on healthcare professionals. Their primary concerns are increased workload, safety of their families, and in the third place is their own safety. Anxiety among healthcare workers precedes that of general public, and healthcare workers may tend to underestimate and downplay the seriousness of a pandemic. This changes, of course, if they have small children at home. About 10% develop traumatic stress, more have some symptoms of depression or traumatic stress. It's safe to put that figure to up to 20%, and some still fresh research out of China demonstrates that up to 50% of healthcare workers had some symptoms of depression or traumatic stress during this recent outbreak. Also, the pandemic will affect facilities and communities. When it comes to facilities, it's very difficult to prepare for a pandemic outbreak. You have shifting priorities. You have to liaise with local authorities, and then you have to provide education. Also, psychosocial and mental component at that time tends to be overlooked, and there is never enough time. And then with communities, you have rumors. For example, 2.3% Americans claim that they have had COVID-19 about 2 months ago. There will be shortages, disruptions. Different populations and cultures have different ways of understanding the scope, and of course, attitudes towards immunization and treatment also will come into play. Then there are special issues associated with quarantine and isolation. Patients who are in isolation can experience despair and hopelessness. Patients in isolation will receive less face time compared to their non-isolated counterparts. They will basically be at risk for being stigmatized, and their risk for developing trauma and PTSD is significantly higher. And just one side note, it's likely that the first description of delirium ever by Hippocrates basically referred to delirium caused by an infectious disease. Quarantine refers to seemingly healthy individuals that have not yet developed signs and symptoms of a disease, but still there is a tremendous toll on quarantined individuals, and basically has been associated with 30% rate of PTSD and depression. Such was the case of SARS in Toronto in 2003. It also can result in social stigma during and well after the isolation is over. Some of the issues associated with quarantine and also isolation are loneliness and boredom, social deprivation, loss of control, anxiety, irritability, insomnia, depression, anger, and acting out. Interestingly enough, two populations most likely to defy quarantine orders are teenagers and healthcare workers. Now, just to be clear, this refers to actual quarantine, not what we've been exposed to in the recent months. So we have some skill sets to develop to be able to deal with this outbreak. We have to be able to provide psychiatric care for patients in isolation. Those are the inpatients with an active or suspected infection. Provide support for the families of those who are sick or have died from COVID. Support quarantined individuals and groups. Provide support for healthcare personnel, and then be ready to participate in the development of contingency plans within our institutions, work with the public and our communities to understand emotional epidemiology and the concept of emotional contagion, and help others learn, kind of understand it. Again, there are a couple of unique features of this pandemic. One is a significant exposure risk for population and providers alike, including mental health providers. So it's not that your risk for getting the disease, at least in Metro New York, is higher at a hospital. Paradoxically, it may be higher in the street. And there is also unprecedented social disruption due to measures imposed after we failed to actually contain this outbreak.
You have to wrap it up.
Here are the challenges that we have to delivering CNL care during pandemic. We have the dual objective of maintaining coverage as close to original service setup as possible, while maintaining flexibility to do a whole bunch of these issues. I'll just leave these slides here, but you have to basically provide for the patients, for your colleagues, for your institution, for the rest of the psychiatric services that you are a part of, and still try to do research and academic work, provide teaching, and also serve as an advocate for your colleagues and patients. This is just the last slide, basically, that, just one thing I would like to say, that remember that L in your CNL title stands for liaison. It is next to impossible to do tele-liaison for a prolonged period of time. Your place is next to your colleagues whenever reasonably possible. Understand that you may be in the best position to advocate for your colleagues' mental health and well-being, and that is the process that I call meta-liaison, then basically suggest that you work with administration to ensure that. CNL psychiatrists should consider a more active advocacy role in this pandemic, because there will be a next one. And as I said, this one is best understood as a warning shot. I'd like to thank you all for your attention. And now I'd like to hand over to Yashni Aliji from Memorial Sloan Kettering in the city.
Yashni, please put your camera and your volume on. Thanks.
Working now? Working now?
Yes,
Yes.
we see.
Okay, great, wonderful. Okay, let's rerun. It's a pleasure to be here. In the next 10 minutes that I have, I'm gonna try to share our experience with you in treating patients with cancer who were also afflicted by COVID-19. So a little bit about cancer and COVID-19. My apologies, this would not stop moving for me. Okay, 1 second. Okay, so we know that cancer patients who have COVID-19 are at increased risk of hospitalization. They're at increased risk of respiratory failure and increased risk of mortality. Early reports from China indicate that about 5 times increased risk of mortality happen among cancer patients with COVID-19. Very similar reports from Italy. 20% of COVID-19 deaths were reported among patients with active cancer. And some unpublished data from our ID colleagues at Memorial Sloan Kettering is about 400 patients that were treated in the first month of the pandemic. The mortality rates were around 20% on regular floors and up to 30% on our critical care units. So what's different about COVID-19 delirium? Likely due to the prolonged and heavy sedation these COVID-19 patients require, patients tend to be waking up more severely agitated. Before even we started seeing patients with COVID-19 delirium, we were already hearing from our colleagues, both globally and also in other New York City hospitals, that it was very difficult to manage these patients. Most of these patients were requiring physical restraints. They were not responsive to the antipsychotics we would typically use in management of delirium. And there were some other challenges, additional challenges involved, such as the issue of prolonged QT. The use of hydroxychloroquine and azithromycin in these patients certainly pronounced the prolonged QT concern from our standpoint. We were also hearing about these medication shortages. We were told by our pharmacists in the hospital that there was soon going to be a shortage of things like propofol, IV fentanyl, Ativan, haloperidol, which really concerned us significantly. There were also a number of redeployed clinicians working in the hospital treating COVID-19 patients. We never got to a point of psychiatrists having to treat those patients, but most of our critical care units, the newly opened critical care unit, to be able to accommodate additional COVID-19 patients, were staffed with pulmonary fellows, pulmonary attendings, and some other people who don't typically treat these patients on a day-to-day basis. So it became clear to us shortly after the first patient at Memorial that we had to develop our own delirium management guidelines to be able to assist our critical care colleagues. So before I start talking about these guidelines that we developed, let me tell you a little bit about our pre-COVID liaison with our ICU. In our intensive care unit, all patients are screened for delirium by use of ChemICU twice a day. If a patient screens positive for delirium, they're assessed by an attending physician or an APP or fellow, and they're managed accordingly. Psychiatry is called in cases that the critical care clinicians are not able to manage. And in our critical care units, there are also a number of preventive interventions that are used as part of the standard of care to prevent delirium in ICU patients. So when we started developing our delirium management guidelines, our target users were really the people in the trenches, such as critical care APPs, ICU fellows, house staff, who had to manage these patients in the middle of the night or during the weekends when they didn't have a lot of support from attendings or other professionals. So a number of our critical care clinicians, a few of us from psychiatry and a clinical pharmacist sat down, and I would say in a span of 48 hours, we drafted an algorithm. We kept in mind primarily, first, do no harm. Right? We have to make sure that that we do minimize any risk to these patients. So with that in mind, we save medications such as chlorpromazine, UPA, or ketamine, or higher doses of antipsychotics for the expert, meaning that's us. Okay. So this is kind of how our guidelines look like. It really follows what ICU clinicians are used to looking at, right? The initiation phase, the patient's intubated in the first 24 to 48 hours. They typically would sedate their patients with propofol and fentanyl. And then as they move on to the maintenance phase, the propofol is decreased maybe a little bit. Fentanyl might be continued for pain. Then they introduce the dex. We typically, in a patient who's on multiple sedatives and who are presenting with a RASS of -4 or 5 or even -3, we wouldn't introduce antipsychotics. However, in the age of COVID-19, our critical care clinicians felt strongly that they had to introduce a sedating antipsychotic early on to be able to allow for these spontaneous breathing trials or spontaneous awakening trials, and to be able to reduce some of these sedatives in a timely manner. So hence our quetiapine here. And then during the de-escalation phase, that's when the ventilation is being weaned gradually, continue with the dex, and maintain your antipsychotics. We also made a note here, which is one of the most important things. In the post-extubation phase, we asked all critical care clinicians to consider reducing antipsychotics and try to discontinue it before the patient leaves the hospital. We also asked them to do daily EKGs. We were able to get our ICU monitors to have a QTC read. So we were able to see the QTC changes throughout the day. We recommended being especially careful with geriatric patients. And most of these patients, since they were heavily sedated for prolonged periods of time, we recommended special caution to benzodiazepines and opioids. When these patients were on benzos and opioids for weeks at a time, and when critical care stops them abruptly, as they would in some of the other critical care patients, that they would use these medications for shorter periods of time, these patients went into withdrawal. So it was really important that those medications were tapered gradually. And we finally said, if you have a difficult case that you can't manage, call psychiatry. If a patient has ended up in physical restraints, MITs are also included, call psychiatry. If your patients start developing rigidity, akathisia, any kind of extrapyramidal symptoms, if there's a QT prolongation, call us, we'll help you manage the patient. And finally, if there were any underlying illnesses that would increase patients' likelihood of developing adverse effects to typical medications that we would use, or an underlying schizophrenia, intellectual disability, bipolar disorder, we also asked for psychiatry to be involved. So having these guidelines did not finish our work. We tried to disseminate the guidelines broadly. We were sending daily check-in emails, as a matter of twice daily check-in emails to the floor nurse leaders to kind of identify these high-risk patients. We were receiving a daily report of all critical care COVID-19 patients on medications of concern to us, kind of reviewing those medications and doses and calling the teams if we were to see anything of concern. But despite all these efforts, we were still seeing patients, we were still receiving consults for patients who were in benzodiazepine withdrawal after being stopped abruptly off of their benzos. Or we've had cases where patients were on high doses of antipsychotics while they were at a RASS of -4, -5, meaning when they were comatose on multiple sedative medications. So we said, we need to get here. We need to liaise more closely. We need to do something about this to be able to help patients. So what did we do? We embedded we have 6 fellows every year. So we said, let's embed each one of our fellows to the 5 critical care teams that we have. So each one of these fellows started working with critical care teams on April 27th, which was around the 7th week of the pandemic. Our fellows would check in with the critical care teams on a daily basis. Some of them were able to attend their inpatient rounds. They would review the patient list. They continue to emphasize using the guidelines. And if there were any patients of concerns, we would consult on those patients. Our fellows were able to get a QI project out of this, and they were able to have lectures from 2 of our critical care attendings, which was really nice. We had 1 CL attending supervising all these cases to be able to ensure some continuity of care, and the CL attending would also do weekly check-ins and staff all patients in person. So if I had to summarize our experience, what went well? I think having guidelines was important. Having guidelines was important because it helped the people in the trenches, as I mentioned. Having an embedded fellow for each of these critical care teams was extremely helpful. Our fellows knew those patients from earlier in the course of their intubation. And so when these patients started getting delirious, they were able to manage much more attentively, and they knew much more about the patient. What were some of the anticipated or unanticipated challenges? We knew that COVID-19 was a beast. We knew that the COVID-19 brain would even be worse, and it was indeed. But what we didn't really expect was having to master critical care medicine. We found ourselves in this a steep learning curve of what are these WEN settings? What's this PEEP score, or how do we manage these patients? So it was quite a challenge. So what did we learn? Hopefully you will soon read this in a published manuscript. But
Please wrap it up.
Okay,
please
sure.
wrap it up.
Okay, I will. So we treated about 30+ patients. We were involved in only select cases, so these are the 30+ patients. But in all those cases we were not involved, we were familiar with the patients. We had a few patients who were on MITs, no real physical restraints. We were able to identify side effects in a timely manner. We were able to manage most patients just with use of DEX and low-dose antipsychotics. There were a few cases, maybe 2 or 3, that we had to use ketamine, BP, valproic acid, or chlorpromazine. Showing up in person made a huge difference to be able to educate the bedside nurses. And just being patient with COVID-19 patients, but also aiming for lighter sedation. As much as these patients require heavy sedation for a number of weeks, they when the time comes, it's very important to lighten the sedation to be able to protect the brain in the long term. So what are some considerations for the future? Get your algorithm ready if we have a second wave. Get involved early, embed a psychiatrist to all of your critical care teams, and prepare to show up in person. It makes a huge difference. Thank you, and let me turn to our next speaker, Dr. Lisa Rosenthal.
Hello, it's wonderful to be here. I really appreciate being invited by Marilyn and Paul. And Paul, thank you so much for setting up this awesome COVID listserv where I feel like we have a direct line to all of our CL heroes to ask questions. I'm going to try to synthesize some of the literature for agitation. As was already said, it's been a steep learning curve. And again, thank you to all of the CL members who actually have done the academic work of creating the literature. I'm coming to you from Northwestern Hospital. We've had more than 1,100 COVID hospitalizations. Number of them have been in the hospital. I don't have any proper disclosures. I thought it was worth mentioning that I received 5% of my salary for a study sponsored by Gilead. Gilead happens to be the drug company that makes remdesivir, which is completely irrelevant to the little study that I've been working on, but wanted to mention it since this is a COVID talk. Anybody who's heard me talk about agitation before might remember that I have a theory of fundamentals for responding to agitation. It may be a little counterintuitive, but I really think that the most important thing to think about when you go back to basics is, where is your patient? And that's true for COVID patients, that's true for non-COVID patients. Are they on a general medical floor? Are they in the intensive care unit? The second consideration for agitation is, how bad is it? People who are extremely agitated need rapid intervention and strong medicines. People who are presenting a very high risk to themselves or others also need rapid intervention. And then we can ask, why is this person agitated, to target our treatments a little more. The example, one example would be a patient that we saw recently who was COVID positive, agitated on a general medicine service, who was spitting at people and refusing to stay in his room. Obviously, the risk to others was of primary importance there. And the fact that he was on a general medicine ward, where what we have is Haldol and Ativan stocked regularly, is very important. So we started there and have really tried hard to manage patients who pose a risk, particularly to healthcare workers. The other thing, of course, to remember is to first do no harm, as was already said. We don't want to overly sedate people who are already having difficulty breathing. And especially in the aftermath of George Floyd's death, I think we have to acknowledge that there are many disparities in our culture and within medicine, that when we make subjective diagnoses and put people in restraints or remove civil liberties, we need to keep it in our forebrains that there are disparities even within our communities. Also, we got to educate everybody about the stigma of our medicines. I always quote Kira Chisholm, who says, chemical restraint is tear gas and mace. It's not the evidence-based use of medicine for a therapeutic indication. And our colleagues often overemphasize the risks of meds and don't understand the risks of agitation. Obviously, in our spitting patient, they recognize the risk to themselves, but they don't always recognize the risk to the patient from agitation versus risks like QT prolongation. Like many other hospitals, this incredibly busy slide shows you our sedation guidelines. We helped develop this with the neurointensive care and the CCU and the ICU. We have here extremely high doses of multiple sedatives. What I'm going to focus on is some of the items down here. This is a close-up. You can see some of the dosing we're recommending for antipsychotics. And because I only have 10 minutes, I'm going to talk very briefly about clonidine and valproate. So I'm going to focus mostly, if we go back to the fundamentals, where is the patient? The patient's in the ICU, and this particular patient is still in our ICU. He was a 37-year-old man with COVID who has absolutely astonishing level of agitation. He's improving a great deal from his COVID, but as our colleagues have said, there are a lot of different hypotheses about why we're seeing such severe agitation in COVID-19. At the bottom, you see a brand new reference from last week in the New England Journal. It describes some of the neurologic symptoms found in COVID patients, but there may certainly be a direct viral effect in the brain, as well as the high risk of stroke in these folks. There is a high risk of delirium from cytokine release syndrome, as well as the incredible polypharmacy on our pathway that I just showed you, and all of the other factors that we know are associated with delirium. This patient was on amazing doses of medicine when we first met him, including midazolam, ketamine, hydromorphone, phenobarbital standing doses, and intermittent paralytics because he was desynchronized from the vent. We were unable to use propofol because of his triglyceride level, and they had attempted to use Dex and it didn't work. So what we attempted first was a trial of valproate and haloperidol. If you look at the bottom here, you'll see some of our wonderful ACLP colleagues who have done the academic work behind the limited evidence for the use of valproate in the ICU. Valproate, we also don't know how well how it works, but it may increase presynaptic GABA levels. It's important to remember that it's highly protein bound, and while it's not clinically clear how relevant this is, the free fraction is often likely to be elevated in the intensive care setting. It has complicated hepatic metabolism, which may not be real problematic for short-term use, but it also, as you all know, causes hepatotoxicity, pancreatitis, low platelets, hyperammonemia, and we don't really know how it interacts in COVID-19 patients. For anybody who attended a wonderful talk last year by our own Dr. J.J. Racimus, he has an interesting theory about the use of valproate in intensive care patients. He showed a really pretty picture of the valproate molecule, which is a fatty acid. And while I don't usually focus on molecular structure, the point is that fatty acids are used up in the hypermetabolic states of critical illness, particularly when patients are NPO and not eating, and that in these hypermetabolic states, you will probably need much higher doses of valproic acid or valproate, which is what it's called IV. We are recommending loading of 30 milligrams per kilogram, which took some discussion with our pharmacy team. And then every 6 hours, about 750 milligrams. Depakote can interfere with urea cycle function, and so it is very important to give levocarnitine when using Depakote. You can check a trough level very rapidly and get an idea. We have not yet seen a patient with even a therapeutic level, even with these high doses. Be careful with valproate and fentanyl, and you should always consider checking ammonia and lipase because of the risks. For our case of extremely agitated person, we checked his ammonia level the next day, and it was 121. I don't know if that was due to the valproate that we started. He already had some hepatic dysfunction. He then developed priapism, and so we had to stop antipsychotics. It turns out that he's somebody who gets priapism 2 to 3 times a year anyway, and now 3 weeks later, he still has priapism. His MRI was quite interesting. He had some hyperintensities that were thought to be due to general inflammation, but I think, like that New England Journal of Medicine article this week suggests, there may be direct CNS effects. His TAP was benign, and we didn't really find an exact reason for his severe agitation. He continues to be waxing and waning, very febrile, and on many, many medicines. We had to stop beta blockers and multiple medicines because of the priapism. So then, as his COVID, we call it hot COVID, became cold COVID, which meant that he was starting to recover, at least for some of his lab and ventilator parameters. We initiated dexmedetomidine as well as clonidine. Clonidine is a central alpha agonist. It reduces sympathetic outflow from the CNS, and basically it helps with sedation, it helps with anxiety, and it has also been shown to reduce analgesic requirements. There's 2 studies, and they suggest dosing is about 0.3 milligrams per kilogram. This is interesting. We all know clonidine can lower blood pressure, but it's actually a dose-related response that's nonlinear. Many of you have seen this slide from Dr. Jose Maldonado, who taught me everything I know about adrenergic agonists, and suggests that clonidine, guanfacine, and dexmedetomidine have different receptor profiles, and it might be good to refer to his article cited below to think about which one might be appropriate for your patient. Our poor guy is slowly improving. He continues on pretty high doses of opiates, dexmedetomidine and clonidine. We haven't tapered him fully yet, mostly because of his priapism. I also want to just let everybody know who hasn't seen these, I hope you have, that Psychosomatics is rapidly publishing some great articles, many of whom are also by our fabulous colleagues, and some very good references, including some of the things, as said, we've had to learn an awful lot about the intensive care unit, and I found this mcrit.org or emcrit.org website very useful for understanding some of the parameters in the ICU. And
Thank
again,
you so much.
thank you so much.
Great job. Okay, if the panelists could come back on. We have a few minutes for questions. These slides will be available. They will be posted afterwards, as will the whole virtual forum. And there is unfortunately no CME. We didn't get that organized that quickly. But a couple questions to the panel. I think this is really for Jameer. Suicides have been noted to decrease during COVID. Can you explain that in your model?
I cannot, and I can. I think in every situation where you have a tremendous risk for life, so that would be pandemic, earthquakes, tsunamis, wars, usually the survival instinct kind of tends to kick in and then shifts the gear somewhat. So people tend to be a little bit more motivated with whatever vital dynamisms they have to fight for survival. I think that's probably the shortest explanation.
Okay, and can you comment, or any of the panelists, what is the trauma causing the PTSD in individuals in quarantine?
It's a great question, because seemingly, well, you're healthy and you're kind of in a hotel kicking back watching TV, but not everybody who's quarantined ends up in that situation. A lot of times that can happen at border crossings and whatnot. You may be taken away from your family, separated from them, placed in something that's less than pleasant with no TV, access to communication. Nobody tells you what's going on, and basically you are left to a ticking clock, waiting to see if you get sick and perhaps die, or they say, oh, you're good to go, everything's fine, and you continue with whatever you were doing, either your travel or your life. So the potential for trauma during quarantine is significant, depending also on the context and the duration.
So one comment was, well, should diagnostic thresholds be changed since the whole patient population has had their lives disrupted on a daily basis?
That's probably not the best question for me. I don't think it should be changed. I think that some people had it more difficult than the others, and as I said, what we have been experiencing here is somewhat mid-level social distancing. We haven't been really quarantined. That means you can't leave your house at all for a while, and that hasn't happened. But certainly some people will be traumatized and develop bona fide symptoms of traumatic stress.
Right, and I think one of our panelists may discuss this in our second hour. So one question is, could you, and I think both Lisa and Yasni touched on this, discuss how to manage anxiety in admitted patients with COVID pneumonia, how to balance the benzo use and the respiratory depression, since low-dose antipsychotics can risk dyspnea and rare reports of respiratory distress such as Seroquel.
I mean, I think you have to remember any sedating medication can cause respiratory depression. And so you have to balance the risk and the benefit. There's, the risk of the anxiety versus the risk of respiratory depression. And there's a lot of money waiting for somebody who can develop an anxiolytic that doesn't have that side effect, but I don't know of many or any. So it's hard to say. Every case is different, and sometimes one dose is safe and another dose will put the patient into respiratory distress. And it's very, very hard to predict in my experience. There's great literature suggesting that all of the anxiolytics can cause respiratory depression.
I agree with Lisa, and I think observing those patients who were on respiratory distress was painful. They were severely anxious. Air hunger was hard to watch. So I think it's hard not to do something about it, and using either a very low dose anxiolytic or a low dose antipsychotic is the best way we know how to manage these patients.
Okay.
If I may add, you're absolutely right. Using sedatives is really a tricky road. What we wanted, or what we examined and actually had fairly solid results with is 5-HT2A and C an antagonism. So if you can find agents such as hydroxyzine, or even amongst antipsychotics, ziprasidone, provided your patient is not on HCQ, you can have pretty solid results without suppressing respiratory drive or causing sedation.
I would say one more thing, which is that there's a little bit of theory that dopamine contributes to respiratory drive, and that dopamine antagonists might relieve air hunger a little bit. That's theoretical, but right, it still doesn't mean you don't be careful, but you have to treat the patient in front of you.
So Demir, now that the initial crisis or perception of the threat is over, are there any things that ACLP could do to support CL psychiatrists?
That's a great question. There are several things, and I think you are doing some of them already. One of them, you have created this wonderful repository of resources that are being generated daily, and you have cataloged all of them, and they're available to all our members and even non-members, and I think it's a beautiful thing and the right thing to be done at the right time. The other one is to create this informal and semi-formal network of expertise available in exchange of experiences, and you've been doing that also tremendously. So two things are already done. I think the third thing to do is basically to kind of keep check on your on our members' well-being, to see if everybody's doing fine, whether or not they're being treated fairly or exposed to some undue pressure to do things that they're not comfortable with, because we know that the PPE is not always adequately available, and there are many different manifestations of this disease in various parts of the country. It's not one solution fits all. So I think it's important for us to check with members and see how they're doing, and maybe even make some sort of counseling available kind of informally, so that they know they're not peer counseling, they know they're not alone, that everybody's going through this more or less in the same vein. And the last thing, I think we definitely should do more, and particularly ACLP kind of take the torch on the mental health of a pandemic, and we should do more advocacy, because I said I don't think this has been handled properly. This is probably a discussion for a different forum, but it hasn't been handled properly by the global health authorities and also our authorities as well. A lot of it could have been avoided. Mental health was somewhat kind of forgotten and neglected in the opening period, and will be forgotten as this subsides. So from that perspective, more advocacy role, even lobbying, would be something that ACLP can do.
Can I just say one other thing, which was to revisit the issue of risk of medicine versus risk of psychiatric illness and symptoms. We know that anxiety is a clinical predictor for suicide. We've seen suicide attempts, and I believe a completed suicide on a COVID unit in the United States. And so that does have to be balanced, right? You don't want patients so in distress that they feel suicidal. So again, it's a risk-benefit analysis.
You're referring to patients, not just to the healthcare workers, which we also had a suicide.
Oh, I didn't know that. Oh, yeah. Yes, the suicide in New York, yes, but also patients, yes, all of the above. We're talking right now about treating patients, but we don't want them to be so distressed and uncomfortable that's how terrible they feel, and we don't want to underestimate the risk of psychiatric illness to overestimate the risk of medications.
Right. So I'm going to turn this over to Paul, who's going to introduce the next session. I don't see any further questions in the chat, so we'll go ahead and move on to the next hour.
So very good. It's clear that things have changed radically, and in the second half, we'll be talking about changes in consult operations, and we'll be talking about wellness. And to start our discussion, let me turn this directly over to Nasu Malas. Thanks very much.
Thank you, Paul, and thank you to all the speakers. It's a real privilege to be speaking to this group today and reflecting on our experience, past, present, and in the future with COVID. I am just going to cover a little bit on administrative and clinical care considerations in this environment and things to be considering going forward. I currently serve as our Consultation Liaison Director for Pediatric Consultation Services at the University of Michigan, and also am the Child Hospital Lead at our institution. So in thinking about how we plan and provide care in the COVID environment, we really had three founding principles that guided all of our decisions and all of our actions during the COVID response, as well as going forward. And in an environment with a lot of uncertainty, in an environment where things are evolving quickly, it's really important to have a foundational guidance as to how you proceed. So those three principles include promoting safety and ensuring that individuals that are providing care on the consultation service and within the hospital setting and outside of the hospital setting are doing so with safety in mind and social distancing in mind. We also wanted to preserve personal protective equipment to ensure that that equipment was available when needed, and also to provide high quality care and not compromise the care we typically expect for our patients and families. Along those three principles, I really identified four processes to be considering with every single decision we make. You want to remember, during times of crisis, gaps in care and challenges can be amplified and can become highly problematic. And so being cognizant of that in advance, but also people tend to rise to the challenge and come together, and you can see many strengths really become significantly highlighted. As we go through and make these decisions from a clinical care delivery standpoint as a service lead, or from an administration standpoint, we want to be mindful of the limitations of our staffing models, the limitations of the environment and the workspace that we're providing care, the areas around documentation, care delivery, and we'll have a lovely talk on telehealth next. We want to be mindful of equity, things that you may not consider to be equity issues in terms of changing staffing models or changing how workflow proceeds may be seen by others as being unequitable. And so you can avoid that if you have a large consensus group that's informing decisions, and if you're thinking proactively about the downstream implications of any type of change in workflow. The nature of care is really important, and whether the care that we provide requires direct assessment or not, and who provides that assessment, and what that assessment looks like, and the delivery of interventions can have significant effects, not only on consultation liaison services, but also those that we work with, and being mindful that nursing has a different role than a physician, and so on, and how that can affect the dynamics on a team and affect care. And then ultimately being transparent. There is an inclination sometimes to want to do and not inform or not necessarily share. And it's really important that we're transparent, because knowledge is power during a time of significant uncertainty. And as much as you can share information, it can be very helpful in allaying anxieties. Context matters, and this is a fairly busy slide, but I want to show how our system, our hospital side, evolved. And our consultation liaison services don't occur in a bubble. We often interact with our colleagues on inpatient services, partial hospitalization programs. If you have an ECT program, that can significantly impact how we provide care, as well as our emergency services. And so what we saw at Michigan was a significant decline in consultation numbers initially, and then a rebound here in May. But some of our services did not fully rebound. Some of them declined more, and that had a lot to do with how the health system used its functional space. Our children's hospital had several COVID areas where care was being provided, and that drastically reduced our pediatric population and changed the dynamics in how we provided care on the pediatric consultation service. And that had downstream effects on workspace, workflow, and consultation volume. In addition, the case mix, the acuity went up, and we saw significant increases in traumatic experiences. Our number of filings with Child Protective Services rose in the community. Family dynamics had a significant effect. And our population with autism and developmental delay were lacking services from schools and community resources. And so although volumes declined, the acuity and the relative contribution of that acuity to the total population was significantly higher and became an evolving process that we had to consider from day to day. So in periods of uncertainty and anxiety, it is really important to over-communicate and ensure that you have all stakeholders involved. So at our hospital, we did briefly check-ins for about 15 to 20 minutes across all hospital services. There was a parallel process on the ambulatory side as well. We also did weekly check-ins between hospital leads and administrative leads to make sure we were not missing any gaps in terms of our response and addressing any acute problems. We did twice weekly check-ins with our chair and all service leads across the house. And then I personally got involved in the pediatric calls, which were also 3 times a week. And so I could be informed as to what was going on in pediatrics. Our adult side also got involved in the medicine calls. And we also got together across the entire health system and rapidly developed COVID consultation guidelines to ensure that the type of PPE being used, the way consultations were provided, the type of virtual care was consistent across the house, because confusion and variability can breed a lot of distress. And we were able to remarkably do that in about 48 hours. This is a model of what we would call a modified Lombardi model of staffing. The Lombardi model is based on a model that was developed in Lombardy, Italy. And we modified this, but the principles are the same. And the idea is to provide rapid rotating coverage, both to reduce burnout and to reduce frequency of sustained exposure to the hospital environment, but also ensuring that there is regular coverage for a sustained period of time and coverage by individuals that are familiar with the systems of care, with the individuals providing that care, to ensure that there is the least amount of disruption to the relationships and care environment as possible. We also made a lot of alterations, and as much as we could, we transitioned our meetings, our conferences with patients and families, any type of educational activity or other non-direct face-to-face care activity to virtual care. We socially distanced on in our work settings by actually removing devices or physically shifting the workspace to allow 6 feet of distance. Everybody was wearing masks in the hospital setting. Family visitation, at least on the pediatric side, was cut to 1 individual, and that individual would be there for the entire stay, which also introduced another layer of trauma and complication in terms of how we provide care. And then we had a lot of other considerations, because in psychiatry, a lot of times we work and provide care for patients in shared spaces. And we had to be mindful of that and promoting quality care and socialization, but doing so in a safe way. And I'd just like to leave you all with this prescription for uncertainty, because I think we're just in the first few innings of this, and I definitely agree that we will be dealing with this for some time. And consistency is really important. So people want to have a sense that they're grounded in something, that there's some sense of stability. So having a consistent model, a consistent approach, a consistent way to escalate and de-escalate communications and other strategies, being responsive, meaning not only responsive, but proactive, not reactive. And so anticipating issues that may be coming up. And that should be driven by consensus gathering, but also being clear in our communication, not providing uncertainty in the way that we communicate, having that guided by those guiding principles that I mentioned before, using data as much as we can to help explain why decisions are being made, and making sure that we're engaging a broad group of individuals in those communications. With that, I'm going to hand it off to Dr. Priya Gopalan, who will be talking to us a little bit more about telehealth. She is an assistant professor at Western Psychiatric Hospital, University of Pittsburgh Medical Center. Thank you.
Thank you. So I am going to be talking, about our institution's experience with telehealth and teletechnology. As many of you have done as well, we had to do a very rapid implementation of telemedicine in our hospital system. And for those of you who are not aware, the University of Pittsburgh Medical Center is a very large healthcare system. We have over 40 hospitals within our system, all the way from New York down to Western Maryland. It is very, very large. Thankfully, I only direct a consultation liaison service that covers 9 of the system hospitals, most of which are in Western Pennsylvania. I've listed the ones that I oversee, but the part that I really want to highlight here is that we have been doing telehealth for many years now. So we started doing telepsychiatry consults to rural hospitals in Pennsylvania in 2014, added on a couple in 2017 with plans to add on more as we move forward. So we already had some experience with telehealth, which was definitely a plus for us. It was definitely an advantage. And at the same time, moving in-person consults into telemedicine very quickly posed a very unique set of challenges. And we were figuring out quite a lot as we went along, as I'm sure many of you all are. I wanted to take just a very quick moment to give a shout out to the people who were involved with this. So the very first step of what we did here in Pittsburgh at UPMC was to actually put together a very quick task force for CL and COVID. Because my team is very large, I had a lot of people kind of step forward and say, we want to help. Speaking to Dr. Mallis's, what he said about kind of people rising to the challenge. So I don't have time to go through every single individual here, but what I really wanted to point out is we had a solid group of attending physicians, resident physician, we had our office staff involved, we had nursing representation, people who really kind of knew their discipline and were able to convene together. And the tasks that were part of that included developing workflows and processes, coming up with a manual for our entire team to use, and we have about 50 individuals, not all full-time, who are part of our team, creating clinical case scenarios for people to have as guidance, and also giving some parameters around, when should we do something in person, when should we do phone versus video versus an e-consult or a chart review. So, I just wanted to give a shout out there, but also to really reinforce that it really does take a team effort. And this group allowed me to put together meetings with 2 hours notice to sort of be the brain to sort of say, no, what you're saying makes totally no sense at all, or to say, no, this makes sense, let's do it this way. In the state of Pennsylvania, we had our first reported COVID cases on March 7th. That was around the time that we also created our task force. Shortly thereafter, on March 13th, the governor closed all of our schools, and that was around the time that we decided very rapidly that we needed to do something for a telehealth conversion. So this involved many, many different things, but ordering equipment was a part of that process, figuring out software logistics, figuring out credentialing and workflow training. All of these things were happening kind of simultaneously. And the really unique thing I think about our service in particular is that at the same time, I was asked to join a UPMC system-wide work group for inpatient telemedicine. And I say this because I think it is really important for us as CL psychiatrists with our footprint across all of these various medical hospitals to really inform system-level care, and that's what we were able to do. So we were at the table with the ID physicians and with the pulmonologists and the critical care docs, talking about how to convert all of the 40-plus hospitals in the UPMC system to have inpatient med surg and critical care telemedicine capabilities. So this was kind of a pretty big deal for us. March 19th, the governor shut down all of our non-essential services. We had our first test patient for telemedicine for our service in particular around that same time. Statewide stay-at-home order happened on March 23rd, and around that time we were ready with our logistical manuals and things like that, things to help our team out in terms of figuring out some of these logistics as we converted our service over. And then we started a rotation system for our staff as well in terms of telepsych implementation, similar to what Dr. Malice was referring to as well. So at the same time as this, the system work group was having very regular meetings about 3 times a week, and we were getting a lot of guidance from that group in particular about billing and documentation, and getting clarification on some of those logistical details, because obviously those details don't go away during a pandemic. We had a system deployment of laptops across all of the inpatient and critical care units in the 40+ hospital system that we have here. Nursing training that was happening kind of simultaneously across all of these units. And about a month after we converted our own service to telemedicine, all of the UPMC inpatient units had telemedicine capabilities. And much of this was driven by our service's own conversion, as well as these other physician groups that I was referring to, ID and so on. So it was kind of a cool thing to be part of that system group. UPMC is also very unique in that it is not only a very large healthcare system, but it is a payer provider healthcare system, and it is also a very robust academic environment. So there were a lot of stakeholders to take into account when we were talking about our conversion to telehealth. You know, we had to align ourselves with what the medical school was doing, with what the Office of Residency Training was doing. We have 2 CL fellows that we had to take into account. We have moonlighters who rotate with us on the weekends. We have our attendings, we have our nurses, we have other clinicians in some of our rural sites who serve as our initial point of contact. We have a central office who receives consults across all of these places. And then we have all of the other network hospitals within the UPMC system that I don't personally oversee, but who sometimes collaborate and consult with us, and oftentimes kind of consulting with us to try to figure out their own processes and what fits with the local hospital culture. And of course, all of this is with the support of the UPMC telemedicine group and our Western Psychiatric Hospital telepsychiatry group. So there was you know, a lot of players to take into account. Telehealth considerations in particular for our institution, we had to think about the platform that was being used. UPMC uses VidYO because of its security options. And we had to think about all of the different types of ways that we could use it. So with VidYO, we had the option to go direct to patient's device, where we could actually just do telemedicine directly into the patient's room. But as many of you have experienced, not all of our patients have access to technology or are able to engage with it. So we did develop a system where we had service tablets as well. And this is what we rolled out initially. And then eventually we got to the point where we are largely using laptops that are present on all of the units. We had to think about weekdays and weekends. We had to think about all these different logistical kind of considerations. And thankfully, again, we had a work group that put together all these great workflows and protocols. This is part of our manuals. I'm not going to go into a lot of detail here, but we had different workflows kind of worked out for every possible scenario, whether it's direct to device or to a tablet or to a unit laptop. We also discovered, as many of you did, I am sure, that there are a lot of patient factors that can be very limiting when it comes to telehealth and teletechnologies. So, you know, if a patient is very delirious, if they have a major neurocognitive disorder, they may have more trouble engaging with the technology. If they're hearing impaired, or if there's a need for interpreters, it's certainly not insurmountable, but it certainly added another layer of challenge. So, you know, there were a lot of kind of clinical factors. Certainly a physical exam was required, that often did require an on-site presence. But there were also, Pennsylvania has very complicated commitment laws. So there were commitment things that kind of came up. And we did end up having to have a small in-person presence across all of our hospitals. We did have to think a lot about scalability. We have 9 hospitals that I am directly kind of interfacing with. So we had to think about scalability, which has its pros and cons. The pro obviously being that we have a very large kind of staff personnel that we could think about in terms of rotation systems and so on. But the obvious con is that it's 9 hospitals across a very large geographic span. And then as an administrator, I had to be thinking a lot about numbers and got asked a lot about numbers and volumes as well. So I'm not going to belabor this or spend a lot of time on this, but it was very, very helpful for us to be tracking not only the total numbers of numbers, how it compared to the year before. And we saw kind of a drop off initially that's starting to pick back up again. But it was really useful to really think about the breakdown in terms of how we were providing care. So if you can, I'll sort of walk you through this graph, but in March we had the vast majority of our visits were in person. That orange bar there is our tele-video visits, the gray is phone visits, and the yellow are chart reviews. In April, you can see that that number has shifted significantly, so that the tele-video visits form a larger proportion. And then by May, we had really mastered the video component of these telehealth visits, where that was the majority of what we were doing. This is just sort of the same thing said a different way. The orange line is tele-video visits in comparison to the other types, but this was week to week. So you can kind of see, as we got the hang of the telehealth and televideo in particular technology, that orange line went up week to week. It was very, very helpful to me to be very vigilant about some of these numbers. Some of this we were able to pull from a data analytics dashboard. Others we were tracking manually. But really being able to break some of the volumes down week to week was, enabled us to be able to show this kind of curve of, yes, our volumes are picking back up. We're doing televideo visits more. This is going to be sustainable. So to kind of bring this all together, our initial stages really involved conversion, training, conversion, sort of thinking about it as a planning period, moving into a more implementation phase, certainly, guiding the system practices along this too, which made it a very sort of unique experience for me, and expanding it across all of our hospitals. And now we're kind of in this phase 3 of revision. So, what are normal operations? When do we go to that? Which parts of this, new technology do we keep? I think that's a big kind of question. We've learned a lot of lessons on this as we've moved along. So it really does take a village. We had a fabulous group that was working on all of this together. We needed to kind of build technology that worked with the clinical workflow, that took into consideration things like physical examination and commitments status and that kind of thing. But really that, an individual service can actually inform a system, which is great. We just have to make sure that we are at the table. And this I didn't really talk about, but I thought was worth noting. At the same time that our service switched to televideo, telehealth consults, our ambulatory services flipped on a dime. Within 3 days, they were doing all telehealth visits, which actually ended up being quite useful for our service, because now, these rural hospitals where we've been doing telehealth for years, we're able to refer to now our tele-geri psych service when we couldn't do things like that before. So there were some secondary benefits. I think there are some things that we really have to consider now that we're in this reflective stage. Some of that is, what are our criteria for resumption of telepsych services? Like, what do we use to say, no, it's, we're not going to do in person anymore. We need to flip it back to our rotation system. I think we need to be very thoughtful about thinking about what we should maintain. I've already had conversations now with some of the hospital leadership in the medical hospitals about whether our on-call, especially when our residents are doing home call, whether they can leverage the unit laptops instead of having to come in the middle of the night. So, there are a lot of questions that are now at play in terms of the telehealth technology. With that, I'm going to turn this over to my colleague, Dr. Vera Foyer. Thank you for your attention. If I can figure out how to do this.
Yes, hello. You're good. So hello, everybody. My name is Vera Foyer, and hopefully you can see my screen. And I am going to spend just a few minutes talking to you, introducing the topic of stress response and psychological trauma in our health system, and our role in helping our health system and healthcare providers with that. I am at Northwell Health. I am also a pediatric psychiatrist, and our health system is a large health system with 20+ hospitals that has been at the hotspot in New York in this pandemic. So first, I just want to talk about a little bit this idea of hierarchy of resource needs. So similar to the Maslow pyramid turned upside down, we have the physical needs, and a lot of different things around physical needs have to be supported in a situation that we were in for the last 12 weeks. And that's sleep, exercise, relaxation, meditation. In a health system context, that can be supported. Employees can be supported with various apps, webinars, videos, things that the health system does. for them. And this end of the spectrum is also, when we're talking about mental health promotion, it is towards that preventative spectrum of helping people provide for this, creating habits, supporting resilience, so that we can prevent problems from happening down the line. And next, further down, we have emotional needs. And when we're thinking about how we're meeting emotional needs in the hospital context, a lot of places, a lot of institutions around the country organically, very quickly grew various different peer support and relationship building structures supporting resilience. There has been in a lot of health systems like ours, a lot of different players in creating this. So employee health, wellness networks, liaisons, committees, HR, occupational health, social work, chaplaincy, sort of everybody organically drew different supports that they could around the healthcare providers to help support their emotional needs. And then belonging and feeling connected as a community, having hopefully concise, compassionate communication from leadership, and supporting feeling belonging to our group, and then making meaning of our work and helping them make meaning of the work that we're doing or that they're doing. When we're talking about mental health promotion skills, so some of these universal interventions are more towards the preventive end, and then certain people need more, and selective groups, at-risk groups or high-risk groups might need more detailed interventions, more intensified supports, and I'm going to talk in a moment about that. And then a certain section of people will need treatment, and how do we in the system identify illness, provide access to early treatment, and then to those who needed standard treatment, and then going into that recovery phase. Because this period has been such an extended period of time and such a long time that we're spending in this very high intensity stress and environment filled with all kinds of traumatic experiences in the healthcare context. People have been spending a lot of time on prevention, some on treatment, and people's ability to engage with that really varies as we move through these phases and as we move into the different phases of the pandemic. So in our healthcare system, just some examples of the different levels of support that I just talked about. So universal support, we have lots of apps, webinars, websites. We have daily mindfulness practices. They're providing yoga classes, different discounts, financial support. The hospital cafeterias turned into little supermarkets for the staff to be able to meet their needs while they're on shift at the height of the crisis and our surge, supporting things like grocery delivery, social connectedness, and then utilizing our recognition program to recognize people for their work. All the hospitals develop these tranquility tents or relaxation rooms where people can go take a break during shifts, and then lots of institutional support that had been provided to the employees. And then at the level of the selective supports for people who need more than that universal preventative streak, when we move to over on that spectrum, we have the peer support, which can be individual support, group support. We have spiritual care services and chaplaincy, a 24/7 emotional support hotline that employee assistance program and behavioral health service line operates together, where people can call in distress, and then also where they can get help in getting connected to more care. So at this level, that illness identification starts to happen in some of these different services that are being provided. People are being identified as perhaps needing even more support, and we're moving again on that mental health promotion spectrum towards illness identification. And then, leadership training on how to recognize issues in staff, having stress first aid consultation to leaders so that they learn about those concepts and how to help support their teams. And then when we move again, one over on the spectrum to the early and standard treatment starts, and these are places, things that folks that have need for indicated support. So things like stress first aid one-on-one sessions. We have a large psychology team across the health system that had gotten trained and provides that level of support for folks when they need it. And then our employee assistance program providing short-term counseling, and then linkage with services within the health system. And in our large healthcare system, we're just trying to figure out how to sustain all of this on the long run, and developing constructs where each hospital or each service line subspecialty has a behavioral health service senior psychiatrist liaison, folks that people know that they can go to if they do need to get connected with more indicated supports and treatment possibly, and then continuing utilizing all the other teams to continue to provide these other levels of supports. So with that introduction to this topic, I would like to pass it on to Dr. George Everly so he can talk to us in more detail about all of this. Thank you.
Well, thank you very much. It's a privilege to be with you today, and I very much appreciate the previous presentations, especially Damir and Vera, because I think my presentation will come into play and be seen as a bit of a continuation, hopefully. Let's see. So the presentation is a model of psychological phases of disaster and response. I'm reminded of a parable that reportedly originated in the Indian subcontinent. It was a story of a group of blind men who sought to discover the nature of an elephant. So they examined various aspects of the elephant. They came together and tried to describe it. As you might imagine, the collective description was rather chaotic. I'm a disaster psychologist, and the field of disaster psychology is a nascent one. I guess really with our origins around 1992. So the whole idea of studying disasters from a psychological standpoint is really quite consistent with Damir's comment, where there are parallel pandemics, the physical and the emotional. So what I'd like to do is share with you today a way of looking not from the blind man's perspective of the microanalysis, but rather from the macroanalysis. Strategically, what can we learn? So what I'm suggesting is the use of an integrative model that helps us understand the phases of the disaster and perhaps will guide us at matching responses to the phases. So again, we don't want to make the mistake of taking a snapshot of one phase of a disaster and making important clinical decisions that may not be relevant sometime in the future. Well, having some problem advancing the slides. With other things. So,
George, would you like Holly to advance them?
I think I'm stuck. Holly,
Okay,
would you
I
be
will.
able to show Dr. Everly's slides?
I will. One moment.
That would be fantastic. Thank you.
Good thing we have a bit of a level of redundancy here.
Okay. All right, thank you. Well, we'll go through this as best we can. So, two lenses through which disaster mental health can be examined. The descriptive, phenomenological, and the prescriptive. And of course, things like this are happening. So here is the phases of disaster slide. The slide is an expansion of the work of Myers and Zunin. And they developed this model pretty much on face value, a case study empiricism as early as 1990. What my colleagues and I have done is to expand it and update it. So the notion here is that disasters are dynamic things. So if we can understand that that dynamism calls for different levels of understanding and different levels of intervention, perhaps we're better suited to appropriately match interventions with different phases. So this model runs through the idea that there is a pre-impact, a warning, an impact, in this case where the agent is made basically known. And you'll see that psychologically, there is a decline. And in that impact phase, we have confusion, we have anxiety, we have fear, and some people, we actually have denial. We mobilize our resources, whether it's in the hospital, the health clinic, whether it's in the community from a public health standpoint. We do heroic things. Heroism is usually fueled by adrenaline. And as you might imagine, that adrenaline is going to be exhausted at some point. At some point when we get through the pandemic, and I would suggest to you we are now kind of entering this phase, we'll call that the honeymoon phase. This is the collective sigh of relief. People had this, wow, we made it through, isn't that great? Some people, however, go right from the heroic into the disillusionment phase, but most people enter this psychological sigh of relief phase. But where the role, I think, of the consultation liaison psychiatrist and psychologist would be is in the next phase predominantly. And that's where the initial idea of disaster mental health was most applied. It's the disillusionment phase. This is the letdown. This is where people take an inventory and they say, wow, I'm glad we made it through, but why did we have to lose so many things or people? And people turn to anger. They blame people. They enter the grief process, depression, and the like. And the goal, primarily, I would see, of disaster mental health would be shortening this disillusionment phase and helping people ultimately recover and rebuild. If we could see the next slide, please. So what we're concerned with, and especially the role, I think, of the consultation specialist in a healthcare facility, is identifying those at the highest risk. And I think not just the patients, but I also think the healthcare staff. So what we see in the wake of disasters is a casualty, a psychological casualty. And I'm defining that in the broadest context, anyone who can't necessarily discharge their responsibilities. We know that there will be a mental health surge. Demir mentioned that initially. Estimating that surge is difficult. Australian psychiatrist Beverly Raphael initially said that about 25% of a directly affected population could benefit from some sort of psychological first aid, not therapy, not counseling, but psychological first aid. In the wake of the attacks on New York City, we found that that number retrospectively was about 23%. The work of public health scholar Ron Mandescheid estimated about 30%. But you get the idea from a public health planning perspective. We can also use these numbers to predict healthcare casualties in healthcare staff. Next slide, please. So what we did ultimately is try to develop a formula of sorts that would help us estimate the psychological toxicity. We would argue that the toxicity is the single best predictor of downstream psychological casualties. So taking a look at several meta-analytic reviews, we deconstructed them and looked at some of their data, and we found that the severity of the disaster, the duration of the disaster, the ambiguity surrounding the disaster or the agent, as well as resilience, all interacting. So severity basically interacting with duration, with ambiguity, and then of course resilience was a buffer. And I think Damir's comments about quarantining were very interesting, because we see that while resilience is a buffer, quarantining can put a damper or inhibit that buffer, suggesting that things like a pandemic with subsequent quarantining could be one of the most toxic things that we have seen from a disaster mental health perspective. Next slide, please. So we're looking at the macro planning within the hospital, within the community. Strategy without tactics is the slowest route to victory. Tactics without strategy is the noise before the defeat, Sun Tzu would say. Next slide, please. So this is a model that we've constructed out of the Department of Psychiatry at Johns Hopkins. And the concept of resilience, I think, is very relevant here. The notion of resilience traditionally has been viewed as a univariate construct. It's defined in English as the ability to bounce back. It's derived from the Latin. But to bounce back, it means you have to be knocked down first. There's another aspect to resilience. Perhaps we could call it proactive resilience, or perhaps even better, psychological immunity. So some of my studies with special operators, for example, Navy SEALs, found that they didn't get knocked down very often. So we discovered there was actually really two factors to resilience. We'll call it proactive and reactive, or in this slide, we call it resistance, the immunity, as well as the bounce back resilience. And of course, speeding recovery would be the role for traditional mental health psychiatric interventions. Next slide, please. So what we've done here is to simply take the Zunin and Myers construct of the phases of disaster, and we've populated those phases with what the literature suggests are some of the more frequent behavioral and psychological responses in those particular phases. And I've divided them here into mild, basically, versus severe. Next slide. And next. So the notion here is, and we borrowed this from Theodore Milan, who wrote quite a bit on integrative psychotherapy. And he said the palette and methods of techniques available to the interventions must be commensurate with the unique features of the person or the group for whom the methods or techniques are intended. That also applies temporally, and that's the value of a heuristic that takes a look at phasic trajectory. Next slide, please. So what I've done here is then take the model out of Hopkins psychiatry that takes a look at resistance, resilience, and recovery, and populated it with different interventions that we have used at Johns Hopkins Medicine. So to develop some sense of immunity, we see that leadership is really important. And this can happen after the impact phase, although ideally it happens prior to the impact phase. So we call that construct resilient leadership. It is a construct that has been endorsed by the Institute of Medicine, if you want to read their Ready and Resilient Workforce monograph published in 2013. We'll also talk about appropriate planning, the timing of interventions, and specific training and wellness practices we'll find we would ostensibly believe would tend to immunize throughout the trajectory of the various phases. As far as reactive resilience, we believe very much in peer support models, and I appreciate Vera's comments on that. We basically teach nurses, physicians, even psychiatrists to do psychological first aid. And as one of our vice chairs in psychiatry stated, she said her task was to teach her psychiatrists to not practice psychiatry, but rather acute emergent intervention. Group crisis interventions can be very useful. Again, wellness practices and the chaplaincy spiritual support, especially in times of a pandemic, I think we all can appreciate the role that for some spirituality may play. As far as recovery, in the Myers and Zunin model, this is the moving on, the reconstruction, the rebuilding. How do we facilitate that? traditional psychiatric interventions. Again, this is where the consultation liaison psychiatrist can play a major role. Counseling, spiritual support, wellness, even helping groups that are perhaps theme-based, a grieving group perhaps. And the last part of this reflects a growing body of literature that says that even from adversity, there can be growth, and that field is sometimes referred to as post-traumatic growth. The role of the consultation liaison psychiatrist, I think, is replete through all of these models, whether it is providing supervision to peer support teams, whether it is playing a role in the recovery, guiding the psychiatric interventions, overseeing counseling. But I think one of the least common and utilized roles of the psychiatrist and consultation specialist is consultation to leadership. I would recommend that the psychiatrists have a seat in the command center, or the disaster operations center, as it is sometimes called. We ultimately know that a society and organization does not recover just physically. It only recovers completely when the organization's people, the human resource, recovers. And I think this is a role that the consultation liaison specialist can facilitate rather dramatically. Next slide. Well, that's it. Well, here are just some specific descriptions of some of the interventions I've already mentioned, where they might go from a timing standpoint, from a target standpoint, their goals. And you'll see, you can see the next slide if we could, please. I've just limited them. When we first started taking a look at the whole field of emergent psychological interventions, it was actually in the wake of World War I. The third leading cause of attrition on the battlefield was shell shock, what some might refer to as post-traumatic stress disorder today. The traditional methods of returning people to duty, the counseling, the psychiatric interventions, were returning people at a rate of somewhere between 5 and 15%. Leadership ultimately went to psychiatrists and said, you've got to do something different. Can you change your interventions? And that was largely the birth of psychological first aid, crisis interventions. When they adopted these short-term emergent models, which viewed people as having adjustment reactions for the most part, not more cumbersome psychiatric diagnoses, the return to work rate increased from 15% high to 60 to 70% high. In the 1960s, a lot of these emergent interventions were walk-in crisis centers and telephone hotlines, and now warm lines. As you can see by these last two slides, we've expanded the armamentarium of emergent psychological interventions. I chaired one of the CDC committees on developing disaster mental health competencies. And we have dramatically broadened the array of interventions that one can bring to bear in emergent situations such as disasters. And these two slides represent them. The notion of viewing disaster mental health from an adjustment rather than a psychopathology point of view, I think, is really essential. All we really need to do is choose our tools, match them to the phases, the temporal phases, the psychological trajectory. And I think by doing so, we would maximize our ultimate clinical effectiveness and minimize the downside psychological casualties. So I think that we must take that dual perspective, the macro as well as the micro. I thank you for this opportunity that you've given me to share some of my thoughts.
Thank you so much.
And sorry for all the technological glitches.
Paul, you're on mute.
Can you hear me now?
Yes, and Dr. Everly, please stay on the line. We'll have Vera and Nasu and Priya join you.
Yes, could the panelists from the second half turn on your video? But you know, the panelists from the first half are certainly welcome to participate. So we got a number of questions, and I'm happy to have the speakers jump in. Maybe we can start a bit with the telepsychiatry issue. We're curious, how were you able to start so quickly? Did you have all of the equipment ready, and how did you get the legal documentation requirements worked out so rapidly? By the way, I actually want to plug our member submitted web pages. We do have a superb manual about telepsychiatry from PRIA, and several other institutions have also submitted extensive manuals about telepsychiatry on the ACLP COVID web pages.
Sure, I can try to answer that question. So I think a couple of things that helped us to move a little bit quicker is that the platform that we used had a direct to patient device option. So because we had been doing telehealth to these rural hospitals already, most of our attendings had desktops that were fitted to do telemedicine. So our initial stages as we were waiting for the tablets to order that we had ordered for the bedside was to actually just start out doing telemedicine visits, telepsychiatry visits to the patient's device whenever we could. So that helped, you know, to have a platform that we could just send a link to the patient's email and they could open it up. It wasn't as straightforward as that. Obviously, they had to download the app and so on, but that helped. Our ambulatory services moved even faster than we did. It took us about 2 weeks. The equipment took, and it was mostly because the equipment took that long to get to us. We were also very lucky in that we anticipated that there would be some backlogs and delays in ordering the equipment, so we did it early. We did it actually before our first case actually in Pennsylvania, so we started to anticipate ahead of time. But that helped a lot. Again, the hospital system I work with has a very large legal department and a very large telemedicine department for the whole. So we used some of the existing language that we had already been using for telehealth, and we kind of started with that, and then we modified it as the system sort of caught up and figured out some of the logistics. The other barrier that we had to think through was actually credentialing and medical staff across all of these hospitals. So we were not sort of, what's the word? I guess we weren't enabled to do telepsych. It wasn't the privilege that we had requested from the get-go at some of our in-person sites. So we also had to get permission to kind of start that without going through the credentialing process, which thankfully our institution was very on board with. So that was our kind of process. Start with direct to device, get the equipment a couple of weeks later, and then kind of go that way.
Who brings? I see a question. Who brings the tablet to the room?
So we had a rotation system, and actually it was the ACLP listserv that really helped us with a lot of this. We saw a lot of the rotation systems kind of going around, but we had a rotation system that brought everything down to a skeleton staff, and we put everyone on sort of quote unquote equal footing, if you will. So we had an attending alternating with a nurse, alternating with a trainee, so that we didn't sort of put anyone under, on the chopping block, so to speak. So, we had a system that really kind of worked, but it also extended our expanse because we crossed over disciplines like that and had people kind of rotating across the hospitals. So, and spread them out geographically as well.
Yeah, I see a question too about difficulties working with video. Certainly, we've had trouble with confused patients and also just keeping patients engaged. There's something about being in the room that gets people's attention. And any of the other panelists that want to comment, please jump in as well.
Paul, hi, this is Yashnem. I can try to speak to the use of telemedicine in delirious patients. In the first couple of weeks, because of our PPE shortage, we had made the decision to do telemedicine for all inpatient work. And I have to admit that that was quite a challenge for many of us from an ethical standpoint. Like, are we providing the best care to those patients without being able to see them in person? Or the nurse has to go in with the iPad to be able to show us the patient. So thankfully that quickly changed, and we started seeing patients in person. I think the healthcare professionals obviously are not expected to be martyrs in the face of a pandemic. But as long as you have enough PPE, it's hard to justify not seeing a patient with delirium in person, not checking them for the rigidity or some of the other neurological symptoms that we might be missing.
So I see a question about agitation. Maybe there are a few questions that came in later. Maybe we could still include something about that. Is there something distinctive about agitation in COVID? And is there something distinctive, since we're seeing COVID at higher rates in minorities, about minority response to psychopharmacology or to COVID?
So it's Lisa, and I'm on the line, but I can't. Sorry, it won't let me. It won't let me use my webcam. Oh yes, it will. So first, I'll start with the second question, which is that's a great question. We don't have any data, as far as I know, about response to medications for agitation in minorities. We barely have data about response to agitation, generally speaking, but boy, would that be a great study. Thank you for suggesting it. But I think there's something about COVID. These ICU cases are like nothing I've ever seen before in my career, which isn't saying a lot, but I think we've all had experiences across the country that, and our ICU physicians as well are saying that this is a type of agitation they've not previously encountered, and we don't know what's causing it. Is it a direct effect on the brain? Is it the risk of stroke? Is it the severe hypoxia and the need to get people highly sedated to prevent the vent dysynchrony, and then the attempts to come off of all these sedatives? I'm sure Yasni has other things to add.
Yeah, no, I think I agree with you, Lisa, and I think that's why I would emphasize trying to get involved in the care of these patients much early in their hospital stay. The minute they get into the ICU, if you know what sedatives were used for these patients, how quickly they were tapered. But certainly aside from that, there is something about COVID-19 brain that's more so than our regular, we talk about how brain lags behind the rest of the body in terms of recovery, but more so in COVID-19 delirium. We have now a number of patients who are off of all their sedatives and are just not waking up. And their CSF studies are normal, their brains look normal, their EEGs are only showing generalized slowing, non-specific findings, but they're not waking up.
Have you got any tips for our members about weaning? It sounds like I see a question about more than one question about that, and it seems to be particularly a challenge in some patients with COVID.
I just want to let our viewers know that we're going to stay on until 2:10 because we're coming up to the end here, and then we're going to have to stop. Go ahead.
Yeah, no, I've actually. Oh, I'm sorry, Yasni. Go ahead.
No. Oh, okay. So I think most importantly, making sure that the agitation that you're seeing in the weaning period, it's important to just figure out, is this vent dysynchrony? Are these patients still need to be mechanically ventilated? Do their vent settings need to be changed? Or is the agitation or anxiety driving the vent dysynchrony in these patients? And also just making a note of, are these patients, were they on Versed for weeks on end and now their Versed has been stopped? Or were they on very high doses of fentanyl for weeks on end and now they were suddenly dropped to very low levels of medication? And beyond that, I think it's fair to start with antipsychotics for agitation, being very careful with the QT prolongation, since it happens much more commonly than not in COVID-19 patients because of the other medications used and the comorbidities. But using things that will be least harmful to the patient, right? What do we have most experience with? We have most experience with haloperidol. We know that there's certain antipsychotics that are less side effect inducing. We've had some success with low dose chlorpromazine in a certain number of our patients when they did not respond to the haloperidol or they developed side effects. I also have to say this patient group is way more sensitive to
to antipsychotics than any other delirious patient group that I've ever treated. We have seen akathisia, we have seen severe rigidity, we have seen dystonia in a patient who was also on Reglan, but relatively on low doses of antipsychotics that we've seen before. And the thought behind that is it's possible that these patients acquire some hypoxic injury to their subcortical areas, and therefore they're more sensitive to use of antipsychotics.
Nasser, do you want to comment? There are some special factors, autoimmune factors that we're concerned about in these patients.
Well, yeah, I actually had a question for our panelists. You know, there's the rise in pediatric multisystem inflammatory syndrome that we're seeing. There's 33 cases in Southeast Michigan, quite a few cases, several hundred in the New York area. And if either of you or anybody else in the panel could comment on post-infectious and autoimmune CNS effects of COVID that you're seeing either anecdotally or have cared for, and what considerations should we have in the management of folks that may be experiencing that? Thank you.
I have to say, and Lisa, I'm sorry I jumped in. I'll be very brief. I think there's likely autoimmune factors that are playing a role in the COVID-19 brain. Having said that, it's so difficult to disentangle what's causing what in these patients after weeks of high levels of sedation and multiple medications used. And also, it's not only affecting the lung and the brain, right? Your kidneys are affected, your heart is affected, your liver is affected. So it's really a multi-organ failure that we're seeing. But I don't have any specific cases of an immune encephalitis, autoimmune encephalitis.
I think we better.
I'm sorry, the blanked out for me for a couple minutes, but I think the question was on autoimmune factors. I think, you know, I'm learning a lot about cytokine release syndrome. Avram Mack wrote a nice letter to the editor in Psychosomatics about it, and you know, some of our membership has written about this, especially in terms of cancer medications. It's really hard to know, and people are complex. I wish I could say something brilliant, but I don't have anything that would really be helpful. The delirium is probably multifactorial: direct effect, cytokine release syndrome, all the organ dysfunction that we're seeing. I think your experience with the EPS is very interesting. I haven't seen that personally, but it does speak to a direct effect on the brain.
Okay, and you know, we've got more questions than we can possibly deal with. So let's make sure we cover a little bit the aspect of psychological wellness. I see some questions that are directed towards the last two speakers, I guess. Dr. Everly, what's different about this pandemic?
I think if we go back to that formula, how we can gauge psychological toxicity. I've been to 39 countries for 40 years studying disasters, and I've never seen anything that looks quite like this, especially considering the quarantine, the social physical distancing. So not only is this potentially devastating in terms of severity for some groups, not all, the duration, the impact phase is the longest I have seen in anything I've ever studied. For example, the impact phase for a tornado can be an hour, a hurricane 24 hours. This has lasted months. And then if you take a look at ambiguity, just the conversations we've just heard, we're not sure. I've just heard some very talented, experienced psychiatrists say, I've never seen anything quite like this before. And you add to that ambiguity coming from CDC, from World Health, from governmental agencies. Someone earlier, one of the speakers, I think it was Natsu, said that information is power. I agree with that psychologically. But when you have conflicting information, it adds to the toxicity. And the fourth and final variable in our equation was resilience, which is supposed to buffer it, but we're undermining it by the very things that we need to do to stay alive. So it's very different.
So Vera and George, I see a question too about the nature of the epidemic, natural versus non-natural disaster. Does that affect the response? Is there more anger? One of our audience asks.
So the data the early data suggested that natural disasters were less toxic than what they called technological disasters. And Norris's 2002 meta-analysis would seem to suggest that that was not necessarily the case. What I will do is I'll change the terminology a little bit. I'll say human-made disasters tend to be more toxic than natural disasters.
I see another question, Dr. Everly, about psychological first aid. Can you say a little bit more about how that works? And I see also a question, what's the evidence that psychological first aid works?
So there have been one Cochrane review and one sponsored review by the American, I think it was actually the International Red Cross, on the efficacy of psychological first aid. The last one, if I remember correctly off the top of my head, was conducted in 2011. Both reviews reached the same conclusion, that there was no evidence of its efficacy. But both reviews suggested that there was evidence of its effectiveness based on quasi-experimental design and case study empiricism. Both reviews suggested that it continued to be pursued. We have conducted 2 randomized controlled trials on psychological first aid, and both were published after 2011. And we found that it exerted a anxiolytic effect as well as increased hope, what we call the hope effect. One was an individual randomized controlled trial. The other was for small groups where first aid was practiced. What distinguishes it largely from counseling or psychotherapy, there are numerous variables, but one of the goals is very different. The goal is to help people approximate their baseline level of functioning. The interventions are typically acute. Meta-analytic research says that 1 to 3 interventions is typically what typifies psychological first aid. The idea is to stabilize acute distress, mitigate the acute distress, use it as a platform to facilitate access to higher levels of care. And the research would also, or the review literature would suggest, instilling hope is an important factor. So if you take a look at those variables, stabilization, mitigation, facilitation of access to the next level of care, it appears very different than counseling.
And I do want to invite any of our panelists to jump in if you want to comment about the distinctiveness and how we should be approaching this particular pandemic. Samir?
One of the things that, can you hear me?
Yes, we can hear you. Go ahead.
Sure. One of the things that I think is unique to this outbreak is basically the failure to contain it globally at several opportunities to intervene and intercept. And I think that led to a significant level of demoralization and resignation among the staff, who at the very beginning were exposed to the agent and basically didn't have appropriate PPE, and there was a really scarcity of knowledge and clear instructions and clear guidelines, and people were coming to their facilities basically feeling literally, in words of not one of them but many of them, like lambs to a slaughter, meaning that they probably expect to contract the disease and then suffer the consequences and the complications. And I think that is definitely something that we haven't seen in a lot of other situations, and will result with some long-term trauma and long-term demoralization. And I think someone mentioned moral injury, which is exactly what is going to be kind of an accompanying theme of this particular outbreak. I think that's where we have our work cut out to provide assistance. And that's also what I meant when I said we have to do the advocacy and advocate for our colleagues, because we've witnessed firsthand how they kept coming here to the hospital and going to the units and caring for the patients, while literally terrified because they didn't know what to expect, what level of protection, conflicting information. In words of one of them, last week Jayco came and they said you can't have a tape on your wall or something, and this week it's okay to use basically a homemade mask from a bandana. And I think that kind of sums it up, this lack of support. And I'm really happy that ACLP jumped on it, and as an agency, as an organization, provided support and continues to provide support for its membership.
On that note, I think we'll have to draw our discussion to a close. We'll never go back. I think so many things have changed, including especially the telepsychiatry, the changes in the obligation of the attending and the resident seeing the patient, and how we divvy up the work and how we do our work. I think we'll never go back. And an important agenda for the Academy is to advocate for policies that will allow us to practice medicine in the most efficient way. I think the discussion here has also emphasized how big a job we have cut out for us, that the sequelae in psychiatrists, in our medical colleagues, and the population are going to be overwhelming. So many special features have come out. Marilyn, did you want to make any summary comments?
Yes, I'd just really like to thank everyone at ACLP and Dr. Sharp for allowing us to host this virtual forum. A really special thanks to Holly Reister, who has made this possible. And a special shout out to Nasu Malas and Vera Foyer, my child psychiatry colleagues who helped put this together. And all our moderators and panelists for sharing their time and their expertise on this forum. We really appreciate your time on a beautiful Saturday afternoon. Thanks to all of you who took the time this afternoon to listen to this and improve the lives of our patients, staff, and trainees. And we hope you'll give us feedback on how you feel this virtual forum went and whether you feel there are other needs that we might be able to serve you with in the future. With that, take care.
I'm going to double the shout out to Vera and Nasu for keeping us on track and getting us well organized. Thanks so much. Bye-bye.
Thank you all. Bye-bye.